Welcome to Law and Justice. I'm Jane Mulcahy. This is a special series on the topic of how to talk policy and influence people. And today I am joined by Sir Michael Marmot, a public health expert. Hi, Sir Michael, how are you?
I'm very well, thank you. How are you?
I'm wonderful, thanks. Thank you very much for joining me today. Can you just tell me a little bit about yourself, Sir Michael, your background and your professional expertise, please?
Sure. I'm Michael Marmot. I'm Professor of Epidemiology and Public Health and Director of the Institute of Health Equity at University College London. I'm medically trained, but I did a PhD in epidemiology at the University of California, Berkeley, and then came back to the UK and have worked in epidemiology and public health since. As I've commented, one side effect of the pandemic is I no longer have to explain what the difference is between an epidemiologist and a dermatologist.
Oh, right, okay.
People are familiar with the concept of epidemiologists, but much of what I do is not about epidemics. It's about the health of populations and particularly inequalities in the health of populations.
Thank you for that, Sir Michael. I know you've written a lot about the social determinants of health. Can you tell me and the audience what actually are the social determinants of health and why should they matter to public policymakers and indeed just ordinary members of the public?
Well, I wrote a book called The Health Gap, and the opening lines of my book were, why treat people and send them back to the conditions that made them sick? The social determinants of health are the conditions that make people sick. We define them. I chaired the WHO Commission, the World Health Organization Commission on Social Determinants of Health. And we define social determinants of health as the conditions in which people are born, grow, live, work, and age, and inequities in power, money, and resources that give rise to inequities in the conditions of daily life. So it's everything about the way we live, the social determinants of health.
And in terms then of health equity, what needs to happen in terms of urgent public health or public policy to redress the pre-COVID health gap that has only been exacerbated, I imagine, during COVID-19?
Yeah, part of my argument has been that because of our understanding of the social determinants of health, the health of a population tells us a great deal about how well that society is meeting the needs of its members. So that if the conditions in which people are born, grow, live, work, and age, and huge inequities in power, money, and resources are operating adversely, then you will get poor health of the population, other things equal. And inequalities in health arise because of inequalities in those social conditions. Now, all countries have inequalities in health. We know that if you classify people by their income or their education, their occupational status, or the level of deprivation of the area in which they live, you see a social gradient. The more deprived they are, the worse their health. And we see that in all societies, but the magnitude of the difference between top and bottom, or the slope of that gradient, varies enormously. It can get shallower, the differences can get smaller, and they can get bigger. And so the reason why we need to take action is that everybody below the top is suffering. It's not just that we might care for poor people. You might think, well, I care for the Siberian leopard and I care for poor people. I'll give £10 or $10 to preserve the Siberian leopard. I don't know if there is such a thing as a Siberian leopard, by the way, but I'll give some money because, you know, it'd be a shame if it went extinct. And I feel about poor people, it would be a shame if they went extinct. So I'll put a bit of money towards it. And that's not a bad impulse, but that's very small part of the problem. It's the nature of our society that means the more deprived you are, the worse your health. It matters to you and me as well as it matters to people at the bottom. And having people at the bottom in worse health tells us something rather fundamental about the nature of our society. So it matters because everybody's concerned with health. And the evidence shows most of us are concerned with what we deem the unfair inequalities in health. If other people in society are suffering through no fault of their own, and that's very important, through no fault of their own, most of us think that's not right. And we need to pay attention to the conditions in society to put those things right. And we know what to do. I've been summarizing the evidence for some time, and it is laid out in my book, The Health Gap, and in various technical reports I've done for the World Health Organization, for governments, and so on, that tell us how to take action through the life course on early childhood, on education, on working conditions, on the distribution of income, on communities and housing, and on behaviors, healthy diet and smoking, alcohol, physical activity and the like. So we've got a good evidence base that tells us what to do. And the summary of everything I've just said means there are two arguments. One is a moral argument. Avoidable inequalities are wrong.
No doubt.
If they're avoidable and we don't do anything, that's wrong. That's a moral argument because, and the reason it's wrong is because everybody cares about health.
Yes.
And the second part of the argument is we know what to do. It would create a better society for all of us if we did it.
Is there also, Sir Michael, an economic argument that if you do invest adequately in healthy childhoods and strong communities, and that people have adequate housing and education and access to these crucial things, that we could actually save some of the massive health costs from disease, avoidable disease, down the road?
People have been putting it to me since I got involved in policy discussions, particularly with the World Health Organization Commission on Social Determinants of Health. They've said to me, no government will take you seriously unless you make the economic argument, the one that you've just made. And I've listened to that and I said, yeah, perhaps if you make the economic argument, good, I'm very happy. But my argument's the moral one.
Right, okay.
Even if it's really costly, even if it doesn't save any money. I mean, why do you go and watch football? Oh, you may not, I don't either, but why do you go and watch football? They don't do it because it'll save them money. It costs a lot of money to go and watch football. They do it because it's enjoyable, because it's a good thing to do. It's part of life. We don't do things just because they save money. We don't do it in our own lives, and we don't expect government to do it just because it'll save money. We want them to do it because it's the right thing to do, because it'll create a better population. It'll make us happier and healthier, and it'll have a fairer society. So yeah, there may be an economic case, and I'm very happy for others to make that. I want to make the moral case.
Excellent, thank you. I'm all for the moral case myself, but I just know policymakers and their staff quite like the economic one too.
Of course. And the other one that gets trotted out, well, you know, we live in a democracy, policymakers have a very short cycle, you know, they think to the next election, why should we do it? And I say, yeah, that's all. Exactly. The reason you're in office is just to get elected to stay in office, and that's all that matters.
Right.
Well, if that's it, then I can't talk to you. And if you're a civil servant serving a politician who can only think up to the next election, then we've got no basis for conversation. You've got no morals, you've got no wider vision. All you think about is, how do I keep my job? Well, we've got no conversation to have. But if you think the reason I'm in office is because I want to do something that's good and meaningful and important, then I can help you, because I've got lots of evidence to show how you can do really good, meaningful, important things. And you may not get great results by the time of the next election, but you'll be on a journey that will deliver better health and well-being to the population. Isn't that why you wanted political office in the first place?
Yeah, it should be, for certainly. And why do you think some politicians or policymakers have been slow maybe to listen to your message and the message of other public health experts in this regard?
I could give two answers. I think the first is implicit in the first part of my previous answer.
Okay.
They don't have wider goals. They just want
Right.
to be with us, feels good. They have a chauffeur-driven car, or status and power and goodness knows what. So that's a not very good answer, but I'm sure is part of it. And I think the other part is they have different priorities.
Okay. Health equity isn't one of their main goals.
They'd never admit it. They'd never say, our goal is, we don't care about the health of the population. Our goal is to help the agriculture industry. We're here to represent farmers. And so that's our goal. We represent the farming community, or I represent the business community, or I represent the fossil fuel community.
Yeah.
And my fossil fuel community want to keep pumping out carbon because it's good for their profits. And anything that's good for profits will be good for the society. The old argument, what's good for General Motors is good for America. Well, it turns out that's not actually true. We know that because what's good for some industries is very bad for America or Ireland or Britain.
Sir Michael, I had the pleasure of attending a public health event in Glasgow where you gave a keynote in 2019. Do you think adverse childhood experiences and embodied trauma are linked to the social determinants of health?
Yeah, very much so. I had another discussion. Well, it was a virtual discussion, but it would have been in Glasgow had it not been virtual, a couple of weeks ago, and with an expert on adverse childhood experiences from UNICEF, the UN Childhood Organization. And he reminded me that the original study of adverse child experiences was done in Kaiser Permanente. So they were not poor people.
Yeah.
They were, they had health insurance and in California and so on. So it's not ineluctably, it's not inevitably linked to poverty. But what the evidence shows is that it's more common. Most of the adverse childhood experiences are linked to social disadvantage. And social disadvantage, I see not as a characteristic of the individual, but as a characteristic of the society. And if you read, there was a book coming out of Glasgow, Poverty Safari.
Great book.
Great book. And he talked about what it was like growing up with he didn't call them, as I recall, adverse childhood experiences, but they were, addicted mother, violence in the family. And that was related to the deprivation of that part of Glasgow in which he grew up. So I think about early childhood, I seem to say this a lot in two ways. One is the good side and one is the bad side. The good side is the nurturing, which can come from parents. It can come from good preschool, Sure Start children's centers and the like, that talking to children playing with children, cuddling children, loving children,
Mm.
all those good things that happy childhoods are about. They're very positive and they're good for children's development. They're not just warm and cuddly, they actually help children's brains develop. And then the bad side is the trauma. It's not just lack of the good, it's also the bad, the adverse childhood experiences. And both of those tend to follow the social gradient. The more deprived, the worse it is. And I think of that is not because of inadequacy of parents, but because of social conditions. I mean, take the good side. If somebody like me says to a single mother, you should really read bedtime stories to your children. And her response might be, well, I would if I had a bed.
Sure.
If I knew that we knew where we were going to be sleeping on Friday night, quite apart from having a book,
Yes.
then I'd read bedtime stories. That is, if I wasn't thinking where I was going to get the money to cook them dinner. So it's not that she's a bad parent, it's that she's in bad circumstances.
Relentlessly stressed.
Relentlessly stressed and limited capacity to do things. We're all understanding stress with lockdown, but those of us in privileged positions, like I presume you and me, with jobs that we can still do from our home offices, and we've got the luxury of a home office, we can keep working. So it's relatively okay for us. But if you're in overcrowded conditions and you've lost your job or you've been furloughed and got 80% of your income, it wouldn't be a great surprise if adverse childhood experiences went up, and they damage the children for the rest of their lives.
Yes, indeed. Dr. Wendy Ellis from George Washington University in DC, she's very much into this concept of the pair of ACEs, which bring together the childhood adversity within the home with the community-wide social determinants of health, essentially. But she also argues that a lot of these health equities and behavioral inequities are due to deliberate social policies, deliberate public policies around housing, around race, and that type of thing. And when I spoke to her a few weeks back, or a few months ago probably now, we were discussing COVID impacts and how, in the States, there have been disproportionate levels of infection among certain communities, African Americans, Indigenous Americans, immigrant communities. How can we explain this, Sir Michael? Do you think, is racism and historical trauma a factor in these differential outcomes?
Well, it's interesting that she says deliberate social policies. I would imagine if you asked a politician, do you think it's good? You would like policies that make parents abuse their children physically, psychologically, sexually. You think there'd be good policies? And I doubt that many politicians would say yes. What they would say is, don't blame me, blame them. It's their fault.
The parents, you mean?
Yeah, it's the parents' fault. And one response to them is, well, even if it is the parents' fault, it's not the children's fault. Why are you comfortable for the children to be damaged through no fault of their own? They're faultless in this. And if it is even if it is the parents' fault, don't you want to do something to protect innocent children? Because it's not their fault. But the second, for all the reasons that we were laying out before, is the policy may be based on the fact that certain politicians see it as the responsibility of the parents to be good parents. They don't see it as their responsibility to guarantee a system that gives them enough money to buy food for their children or to pay the rent when the jobs were taken away. when the factory closed and there was nowhere to go. And so it's not so much deliberate social policy wanting to damage children, but it's social policy based on the assumption that if the parents were decent people, they'd get a job and they'd get enough money to get their housing. And it's their fault if they're suffering these things. And my response to that is show the evidence. Don't try and argue it on sort of philosophical grounds. Who's at fault for being poor, the poor person or the system? Show the evidence. I mean, for example, this is not adverse childhood experiences directly, but it is food insecurity. In one of my reports, we published data that for people in the bottom 10% of household income in England to eat healthily, to follow the healthy eating advice, they would spend 74% of their income on food. Now, the majority of people in England, more than half, who are under the poverty line are in work. So it's not that they're lazy or irresponsible or can't be bothered getting a job. They're in work, but they're not earning enough to make ends meet. They're not earning a living wage. So that's why I say show the evidence.
Yes.
But then to come to the other part of what you asked me about what in the UK we've been calling Black, Asian, and minority ethnic groups. The US, Black, Hispanic, yeah, they have shockingly higher COVID mortality. Now in the US, it's compounded by lack of access to healthcare, and which in the UK happily is not the issue because we have a national health service free at the point of use. But the US, they don't have that. So all the structural disadvantages of racism and discrimination, which is a matter of policy, a structural disadvantage, racist policies, all of that is then compounded by lack of access to healthcare. And the Black Lives Matter movement, which it's been around for a while, but resurfaced during the summer after the murder of George Floyd, is an expression of we've had enough, this isn't right. And the president that's just lost the election, although he won't acknowledge it, he somehow seemed to be absolutely blind to that. God knows what went on in his head, but he seemed to be blind to that. This was a statement, a cry of pain and anger, saying, we've had enough, this isn't right, this is unfair. And there wasn't just people of color who were demonstrating, there were Americans of all types were demonstrating. Yeah, it's a statement about the way society operates, and it operates to the disadvantage of poor people. But when poverty and race they're not the same, but when people have both disadvantages, then they're doubly excluded.
In Ireland, we have a small ethnic minority group called Travellers, and they experience an immense amount of discrimination and social deprivation. And in fact, the state more or less obliterated or criminalized their nomadic way of life. There's a study called our Geels from 2010 called the All Ireland Traveller Health Study. And just to give you a few statistics, only 3% of travellers are over the age of 65, compared with 13% of the general population. Traveller men can expect to live 15 years less than the norm for non-traveller men. Traveller women can expect to live to 70, which is 12 years less than non-traveller women. And the suicide rate for travellers is 6 times higher than the rate for the wider population, accounting for 11% of traveller deaths. As a public health expert, Sir Michael, do you think these type of dire outcomes are linked to social exclusion?
Yes, and as a colleague of mine said, we should think of exclusion as a process, not as a property of excluded individuals.
Okay.
So that there's a tendency to think about the excluded as if, well, you're a traveler and that's why you're excluded. It's a property of you. But
Mm-hmm.
it's the process of exclusion that that's causing the disadvantage. And by thinking about it that way, we can think about processes of exclusion elsewhere. So a year ago, we published the report of a commission that I chaired for the American region of the World Health Organization, which is called the Pan American Health Organization. So it looked at social determinants and health equity in the whole of the Americas.
Mm-hmm.
North America, Latin America, and the Caribbean, the whole of the Americas. And what we found was it was indigenous groups that
Mm-hmm.
were excluded. Um, I don't know if you call travelers indigenous groups, they're not really, they come from some other part of the world, but it was the same sort of process that indigenous groups were being excluded. And the big challenge was to recognize that it wasn't that all of the social determinants of health that I talk about were working to the disadvantage of these excluded groups. But in addition, it was somehow not taking into account the culture and traditions
Mm-hmm.
of the groups. So it's very easy to say, well, you travelers, the reason your kids are suffering is because of your lifestyle, the way you
Mm-hmm.
live. Well, yeah, maybe, but if somebody rerun that and say it's because of your religion, wow, that
Yeah.
many of us would find that unacceptable to say the reason you people have poor health is because of your religion. So you better change your religion
Mm-hmm.
or we're not going to do anything about you. Well, if that way of living is important to a group, then trying to work through how we address the social determinants of health without violating other important things that are important to that group's way of life and tradition and culture
Mm-hmm.
is really very important. And with gypsies and travelers, Romani, however, in different European countries, that's a very consistent issue that has to be faced.
Thank you, Sir Michael. I'm aware that you need to rush off. Do you have time for one more question? Okay, thank you. So I've become very interested in community development lately and the role of communities in preventing ACEs and helping people heal from trauma, and I suppose promoting general health and well-being. Are you aware of any interesting work with a focus on public health promotion or trauma-informed community building and engagement and well-being in the UK or anywhere else, Sir Michael?
Yeah, we've been working with the city of Coventry, became a Marmot city of
Nice.
my 2010 Marmot review. They took it on. Now it's being led by local government,
Okay, super.
but they involve the police, the firefighters, the voluntary sector,
Mm-hmm.
housing. I mean, all the relevant agencies, but including the voluntary sector, and to greater or lesser extent, trying to engage various community groups.
Mm-hmm.
And similarly, we're now working with Greater Manchester, who are doing something similar.
Okay.
Um, and I was invited to Trieste in Italy, and it
Lovely.
was really inspiring. They cheated a little bit. They said Trieste is a Marmot city. Will you come? When I got there, I said, "Are you a Marmot city?" They said, "What?"
That's funny. Well, they got you there.
but we said that to get you here.
Yeah.
Well, it was a pleasure to be there and to see what they were doing. And they're working at a very micro scale. I think they called it a nanoscale. So they had social services and education and health services working with the community at a nanoscale, at a very micro scale, to improve the conditions where people are born, grow, live, work, and age. So yeah, there's a lot of good work going on at city, community, local level.
And just continuing on briefly from that, there's a book by a guy called Cormac Russell about rekindling democracy, and he wants to kind of decenter services, really, mainstream services, particularly in sort of deprived communities, which just become dependent on services rather than active citizens. And I'm just wondering, have you any views on what we can do really to help those communities that are under chronic stress and strain with poor health and maybe high levels of crime and addiction, to realize actually that the solutions often lie with them, that they know one another and care about one another, and the state isn't going to necessarily solve every problem? Have you any ideas for how we can bring the knowledge, say, about ACEs and social determinants of health and the importance of relationships to communities for better outcomes?
Well, yeah, I mean, there's a bit of a danger saying, yeah, it's all got to happen at community level. It lets the state off the hook.
Right.
And saying it's all got to happen at the state level, but then it pays no attention to what communities are doing. It's got to happen at both levels. You need the right set of social and economic policies that are happening nationally, but you need to engage communities. And you need to engage them firstly because they know what the problem is. You know, they
They're
live,
the experts in their own lives.
they're experts in their own lives. And secondly, that process of engagement can be a route to better well-being. And I saw this, I've seen it many places, but I saw this, for example, in New Zealand, where I went to a marae, which is a traditional Maori meeting hall, but it's more than that. It's a community development activity. And they said to researchers, if you want to come and research us so you can write some papers, we're not very interested. If you want to come and work with us and in partnership, then we're in. And they pretty much said the same to the government.
Right.
We need you to provide the right conditions for us to do our work, but then we're very happy to work with our community. We represent the community, we represent the traditions, the Maori traditions that we honor and cherish, and part of that. And so they were working with, disorderly youngsters who were getting into all sorts of trouble with drugs and violence and crime and whatnot. And they want the government to invest in education and communities and the like, but they want to work with these youngsters to try and help them get meaningful lives. So yeah, it's got to be a partnership.
Yeah, bottom up and top down together.
Absolutely.
Okay, Sir Michael Marmot, thank you so much for joining me today on How to Talk Policy and Influence People. It's been an immense pleasure. Thank you very much.
My